All right, let's talk about something you hope you never see, but absolutely need to be ready for: managing a radiation emergency. Think of this as your practical, no nonsense guide for that high stakes moment when a major radiation exposure event walks through your doors. Okay, picture this. You're in the ER. A worker from a local industrial plant is rolled in. He's pale, he's weak, he's complaining of terrible nausea. The backstory is a little fuzzy, something about an accident. He just looks sick. So with all the things that could be going on, what is the one single most important question you need to ask him right now? Let that sink in for a second. We're going to come back to it. Now, why is that one question so important? Because what should be at the top of our differential is acute radiation syndrome, or ARS. And you've got to understand this isn't just a burn or a localized problem. It's a full-body assault. It's a systemic illness that happens when a huge dose of penetrating radiation hits the body all at once and starts taking out multiple organ systems simultaneously. So what's the first thing you'll see? It's what we call the prodromal phase. Think of it as the body's first alarm bell. This is where that nausea, vomiting, loss of appetite, and maybe a fever will show up, usually within the first few hours. And here's the clinical pearl you cannot forget. How fast and how hard these symptoms hit tells you almost everything. A really rapid, severe onset, that's a very, very bad sign. It's one of your most powerful early clues. Let's get back to our patient. Shortly after he arrives, things suddenly go south. He gets confused, he has a seizure, and his blood pressure absolutely tanks. He's crashing right in front of you. What does this change tell you? Well, you are now witnessing the neurovascular syndrome. This is, frankly, the worst-case scenario. It means the radiation dose was so massive that it's causing direct damage to the tiny blood vessels in the brain. You get inflammation, you get swelling. It's a catastrophic neurologic collapse, and it's almost always fatal. Okay, let's reset for a second. Imagine a different patient. This one was exposed to a lower but still very high dose. A few days later, they develop a different crisis: profuse, relentless, watery diarrhea. I mean, we are talking more than 10 stools a day. So what's happening here? This is the classic gastrointestinal syndrome. You have to remember, radiation loves to attack rapidly dividing cells, and the lining of our gut is one of the fastest dividing tissues in the body. That high dose just shreds it. This leads to massive fluid and electrolyte loss, bleeding, and now you have a huge risk of sepsis because bacteria are just marching right from the destroyed gut into the bloodstream. All right, another patient comes through the door. This time, what catches your eye is their skin. They have this deep redness, like a really wicked sunburn, over a large part of their body. And in a few areas, you're starting to see some blisters forming. So what are you looking at? This points to the cutaneous syndrome. Skin damage from radiation can be a whole spectrum of things, from that simple redness all the way to incredibly painful blistering. And over weeks, this can progress to deep ulcers and tissue death. It's a huge source of pain and, of course, a wide open door for infection. Okay, now let's go back to our very first patient. Remember that complete blood count you sent the second he arrived? The lab just called you with a critical value, and the results are, well, they're terrifying. His white blood cell count has absolutely cratered. His neutrophils and lymphocytes are almost gone, and his platelet count is in the basement. What does this lab work tell you? This is the absolute hallmark of the hemopoietic syndrome. This is actually the most common form of ARS you'll see in people who survive the initial high doses. The radiation has effectively wiped out their bone marrow, the body's factory for making blood. Without those infection-fighting white cells and clot-forming platelets, the patient is left completely defenseless. Okay, so we've got the syndromes down. We know which organ systems are getting hit, but here's the real million-dollar question for us as clinicians. How do we put it all together? How do we figure out how bad the damage really is, determine a prognosis, and decide who needs what level of care and how fast? Remember that very first question I asked you about the industrial worker? Well, here's the answer, and it's probably the most important thing you'll learn today. The time from exposure to the onset of vomiting is everything. It is your critical clock. If someone starts throwing up in under 30 minutes, they've received a massive, likely fatal dose. If it's within 5 hours, it's severe. Longer than 12 hours suggests a more moderate exposure. This simple piece of history is your best, most immediate prognostic tool. Your next key indicator is in that blood count, specifically the lymphocytes. These cells are incredibly sensitive to radiation, acting almost like a biological dosimeter. A rapid drop tells you a lot about the dose. So look at the count at 24 hours. If it's holding steady above 1500, the patient might be okay for outpatient monitoring. If it dips below 1500, they need to be hospitalized. And here is the critical number you have to remember: below 500. A count below 500 means this patient is at extremely high risk and needs our most aggressive care.
So we can actually take this information and grade the bone marrow damage on a simple scale, from H1 to H4. H1 means mild damage, their marrow will likely recover on its own. H2 and H3 mean there's a serious critical phase coming, but we still expect their own marrow to eventually recover. But H4 means the damage is so profound, it's unlikely their bone marrow will ever recover on its own, and that changes our entire management plan.
Now imagine this isn't just one patient, but dozens. In a mass casualty event, this is where triage becomes absolutely crucial. You cannot waste your time or resources on the worried well. Your focus has to be laser sharp. You need to identify the patients with that early onset vomiting and that rapid lymphocyte drop. Those are the ones who are critically ill, but potentially salvageable. That's where you direct your attention. So back to our original patient. With his early vomiting and plummeting lymphocyte count, he's clearly in the highest response category. We can even use a formal scoring system like Metropol to confirm it. So the determination is made. He is critical. The question now is, what is our action plan? The plan starts with meticulous, supportive care. This is the bedrock of everything we're going to do. First, they go into reverse isolation to protect their non-existent immune system. We aggressively manage their fluids and electrolytes. We use antacids and H2 blockers to protect the gut. We start prophylactic antibiotics and antifungals. And of course, we stand ready with blood products to support them through the inevitable anemia and thrombocytopenia. But can we do more than just play defense? Yes. This is where we bring in our specific therapies, mainly the colony-stimulating factors, or CSFs. These drugs, like G-CSF, essentially kick any remaining healthy cells in the bone marrow into overdrive, stimulating them to produce new neutrophils. The goal here is to shorten the duration of that life-threatening neutropenia, which in turn reduces the risk of a fatal infection. This can absolutely save a life. But think about this. What about that H4 patient we talked about, the one whose bone marrow we think is permanently destroyed? What happens when you give CSFs and nothing happens? What's our final option when supportive care and growth factors just aren't enough? For these most severely affected patients, the final life-saving option is an allogenic hematopoietic stem cell transplant. But this is not a decision you make on day one. The standard approach is to get their HLA typing done early and start searching for a donor. However, you have to wait for a minimal observation period, about 14 to 21 days, to be absolutely certain there will be no spontaneous bone marrow recovery before you commit to this high-risk, high-reward therapy. And as we look to the future, the therapies are always evolving. Researchers are looking at new agents, things like interleukin-7 to boost lymphocyte recovery, keratinocyte growth factor to protect the GI tract, and thrombopoietin analogs to specifically stimulate platelet production. The future will likely involve a multifaceted approach, targeting different aspects of the radiation damage. And this really illustrates the main message here. As the authors of our source material state, awareness of these medical challenges is the need of the hour, and a structured organizational approach will deliver desirable outcomes. It's not just about what one doctor knows. It's about how the entire system, the entire hospital, is prepared to respond. So let's end with the most important clinical pearl. If you take just one thing away from this, let it be this. In a radiation emergency, your most valuable diagnostic tools are your eyes and a clock. The time to first vomiting and the rate of lymphocyte decline are the two simple, powerful data points that will guide your initial triage and your prognosis. Master those, and you'll be prepared to manage one of medicine's greatest challenges.
Make sure to like, subscribe, and share it with your colleagues so we can spread evidence-based practice and improve patient care together.